waiting to start because we are a bit early. These meetings we have, I think it's once every quarter, and it's, hi Kelly, and the idea is just for people in Manna that are involved in the physical health stream to get together and either speak about their own research or find out about more research that's happening. So it's pretty informal. But it's really, really great to have you on board. And I see we still have some other people joining us. And yeah, so I'll mute for now so that I can cough, and then I'll get back to you. And then to those who are not part of Manna that are on the call today, I can see there's a few names that I recognize. I'll put the link to joining Manna in the chat after Prue speaks. And I'm also just waiting on Chris Doran because he said he would introduce you, Prue. So I think we still have a minute to go. Hi, Dixie. It's nice to see you. It's been a while.
Hi, Tracy. How are you? Yes. Good time of semester. All the marking's finished. All the teaching's finished. It's great.
We have trimesters, so we have a 2-week turnaround. So right now, I'm looking forward to Christmas. That's
yeah. I know.
Yeah,
you said if you've got trimesters.
It's somewhat pressurized. So I had a student that used artificial intelligence for 85% of the assessment.
Oh, no.
in a trimester 1 course that was a prerequisite for trimester 2 course. And so he could enroll in the trimester 2 course while we were waiting for the outcome because the turnaround is so tight. So I think there's a lot of knock-on effects, but yeah, given that this meeting's being recorded, I shall say trimesters are wonderful. Hi, Christian.
Hi, everyone. How you doing?
Hi, everyone.
Good. Are you all battened down and ready for your, what's it called, a bomb cycle? Some bomb of rain or something coming your way?
At the moment, we've got blue skies, and the forecast is for sunshine for the foreseeable future. So well, yesterday was wet, but fingers crossed it's dodging us this time. Looks like it's a little bit further south.
Cool. Oh, apologies. One colleague said I sound like I have black lung, and yesterday someone from work asked me to leave with all the kindness in their hearts. I'm working from home today. I would like to just welcome everyone here today, both those that are already part of Manna and the physical health stream and everyone else that's joining us as a guest, but especially would like to welcome you, Prue, and thank you for presenting today. I'd also like to acknowledge that we're all coming from different country and lands, and if you like, you can type that into the chat. and pay our respects to elders past, present, and emerging, and also acknowledging that this land has not yet been ceded. Prue, I'm going to introduce you because I can't see if Chris is here. I'm working on all these different screens, so.
Yeah, I'm here, Tracy.
Oh, Chris is there. Okay, so Chris, I'll hand over to you to introduce Prue to the team.
Thanks very much. Yeah, I would like to welcome Prue. Associate Professor Prue Cormie is an accredited exercise physiologist and a fellow of Exercise and Sports Science Australia. She's an internationally recognised expert in exercise oncology, specialising in the role of exercise and cancer management. She serves as a principal research fellow at the Peter MacCallum Cancer Institute and holds academic appointments at institutions at the Australian Catholic University and University of Melbourne. Prue is a prolific publisher and has secured over $10 million in competitive research funding. Her research has significantly contributed to clinical guidelines, notably as the lead author of the Clinical Oncology Society of Australia's position statement, advocating for exercise as a standard component of cancer care. Beyond academia, Prue founded XMed Cancer. It's a not-for-profit organisation delivering best practice exercise medicine services to cancer patients. She's been provided with numerous awards such as the Exercise and Sports Science Australian Women in Leadership Award and the Cancer Council's WA Early Career Cancer Research of the Year. Prue's a passionate science communicator, better than me, and she's delivered over 230 invited presentations, including a TED Talk, and offers professional development courses through her platform, Exercise Oncology EDU. So thanks very much for agreeing to present today, Prue, and I'll hand over to you. Thanks.
Thanks so much, Chris. I'll just check everyone can see the screen okay? Okay, great. Thank you so much, Chris, for a very warm welcome, and thanks for the opportunity to have a chat today. It's great to be able to kind of showcase what we know about exercise oncology, and hopefully we can steer the discussion to anywhere that kind of piques your interest. So what I'm going to try and do today is give you a bit of a whistle-stop tour of everything we know about exercise oncology. So I want to talk about what we know about the impact of exercise on cancer outcomes and what it means for patient survival, what we know about exercise and its impact on the cancer side effects, and then also about how we actually can implement exercise into routine cancer care, which is a massive challenge at the moment. But before I do that, I just wanted to start, and Chris asked me to give you a little bit of background on myself, which feels quite strange because I never really do this, but I suppose from my perspective, I've always been interested in exercise. I've studied and researched in exercise science for about, 15, 20 years now. So, God, how long has it been actually? It's been about 25 years studying and researching. So I went over to the US to do my undergraduate and master's. I was really fortunate there to get a lot of experience working in a whole range of different research labs and got exposure to really elite performance through some time at the Olympic Training Center and working with the US team over in the Athens Games. So really honing in on the knowledge of how do we very specifically fine-tune exercise prescriptions to maximize human performance. Went on and came back home to do my PhD, but over in Perth. So PhD and postdoc in Perth, and moved over to Melbourne, where I'm based now, really to kind of push this work forward in more of an implementation space at Australian Catholic University, and then now through my work at Peter MacCallum Cancer Centre. So I think for me, it's, I've got a very strong understanding of exercise physiology and the background in exercise physiology, and the things that have really interested me now is how do we actually apply this and how do we put this in practice with a very firm focus on providing pragmatic solutions. So, I find for myself as a researcher, my research doesn't end at a paper. It's all about how do we put this into practice, and I've done kind kind of various things to try and enhance workforce capacity through professional development courses in exercise and cancer, and also try to kind of provide much more access to patients in terms of information about exercise oncology, but also around how do we provide access to services. And this is all kind of working towards this vision of providing equitable access to the therapeutic benefits of exercise. So that's a little bit of a snapshot of my background, and I'm really happy to kind of discuss anything further, depending on if anyone's interested at all. So let's crack on and talk about what impact exercise has on people's survival of cancer. What we now know from grade 1 evidence, phase 3 randomized control trial evidence, is that people who exercise after a diagnosis of colon cancer, specifically in this instance, actually live longer. So their relative risk of cancer death, cancer recurrence, or development of new cancer is 28% lower than those who don't exercise. So you can see these curves here are showing overall survival and disease-free survival. And this is a sample of over 880 colon cancer patients across 55 centres, primarily in Canada and in Australia. So this is our first randomised control trial evidence confirming what we've seen through the epidemiological data for quite a long time now, that people who exercise after being diagnosed with cancer reduce their risk of dying from that cancer. You can see this is a summary of that epidemiological evidence. There's lots and lots of different studies. You can see here, this is a compilation of 136 observational studies involving over 6 million cancer patients across various different types of cancer. It's also comparing pre-diagnosis activity and post-diagnosis activity. And what you can kind of see from these data is that it's beneficial if you exercise before a diagnosis of cancer, but absolutely critically important is if you exercise after you've been diagnosed with cancer, that's when you get a protective effect of that exercise. So you can see here a relative risk reduction of 37% of cancer mortality with post-diagnosis physical activity. And this is comparing people who are exercising, and typically this means doing aerobic exercise versus those who aren't exercising. And that's usually between the highest category of physical activity levels and the lowest category of physical activity levels. We also see that this data, the epidemiological data, kind of follows through in terms of all-cause mortality, and this will be very similar across a lot of different chronic disease groups, that people after a cancer diagnosis, people who are exercising have a lower relative risk of dying from any cause versus those who are not exercising. And this is just one example of a large data set. This is over 11,000 prostate, lung, colorectal, ovarian cancer patients, showing that people who exercise had actually lived 5 years longer than those who didn't exercise. So again, really strong epidemiological data underpinning what we're now seeing coming through in the randomized control trials. The obvious question is, why is this happening? And there's a whole bunch of reasons that could be happening. And in a nutshell, I suppose we don't know. One of the reasons why it might be working is that exercise may be able to actually enhance treatment effectiveness. That's my doorbell going off. I'm so sorry. And this is basically looking at a whole range of different studies from preclinical mice data into clinical data, showing that, you know, there's some sort of modulation of that therapeutic response that's affected by exercise. So it could actually sensitize the body to receiving anti-cancer therapies. It could help transport that anti-cancer therapies to the cancer cells, and it could normalize that tumor microenvironment to allow those more cancer-killing agents to kind of attack the tumours. So it might actually enhance the effectiveness of treatment. We also see data to say that it may actually allow people to tolerate greater dosages of treatment, which again, this just means that the treatment itself is offering a survival benefit. So that may be the case. We also see that there's, and this is from a range of preclinical and early clinical data, seeing that there could be a range of mechanisms driving this anti-tumor effect. And there's a whole bunch of stuff that's going on there that's really interesting. So if anybody's interested in kind of digging into that, please let me know, and I can direct you to some great papers. But it's really around normalizing that tumor microenvironment, changing the vascularization, systemic changes to immune function, and having anti-inflammatory effects, changing the metabolism, all these things that kind of feed cancer's growth, is exercise is working to dampen those down. We don't know exactly what the reason for this kind of beneficial effects, but we know that there's a whole range of things that are potentially contributing to these survival benefits that we see. So essentially, we can see now that people who exercise after a cancer diagnosis have a lower risk of their cancer killing them, or their cancer coming back, or dying from any other cause. So that's really, really important, especially from a clinician's perspective. But what's really important, and what we have very, very robust data around, is the impact that exercise can have in managing the side effects of cancer and the anti-cancer treatments. So the data that I'll present will be meta-analyses of many randomized control trials that we have that's providing strong evidence of these benefits. So despite what patients, and I'm sure what anyone would agree with, you know, the fact that if you're feeling really fatigued, exercise is probably the last thing that you want to do. But we know from a significant amount of randomized control trials that it is actually the first line therapy, the first line treatment. The first thing that you should be doing in terms of managing your cancer-related fatigue is doing exercise. Now, of course, there's a nuanced understanding of that. You don't want patients going out and running marathons and absolutely blowing themselves up. But if you actually prescribe exercise and do exercise in the right way, it can significantly reduce cancer-related fatigue. When we get that prescription right, and we're talking really about the quality of the exercise, that usually comes down to the intensity, and with fatigue also the way that you kind of apply it so that people can get a benefit without doing too much volume. That's when you're seeing the greatest reductions in fatigue. We know, and you guys would know this much better than I do, but we know that exercise in cancer patients mitigates against the anxiety and depression that is very common for these patients. Psychological distress is one of the most common and really hard to manage side effects of cancer. It's almost universal across all cancer types. And we've seen here throughout, again, a number of different randomized control trials that exercise is having small to moderate effects in terms of managing anxiety, depression, and improving emotional well-being. And again, when you start to unpack these data and you start to look at what kind of exercise people were doing and what the environment they were doing that exercise in, the better quality of that exercise intervention, the better improvement in their mental health. I think one thing that's never captured in the data, and I'm sure you guys would probably know this much better than I again, but I think the thing that patients talk about most is what difference exercise is making to them mentally. They might expect what's going to happen physically to them, but what it actually means for cancer patients going through treatment, recovering from treatment, is, you know, getting themselves back to feeling like they are themselves, less like a patient, more like themselves, is such a huge element of the beneficial effects that we see in cancer patients clinically when we're working with them in exercise. And I think it's really undervalued in the research literature and so often overlooked as a reason to help people kind of get going with their exercise. So massive differences in terms of their mental health if we do it right. As you can imagine, you know, there's a lot of different kinds of functional impairments that happens to cancer patients physiologically. The treatments that they're going through in you know, chemotherapy have massive toxicity in terms of the cardiovascular system, really dramatic impairments in people's ability to do everyday tasks, and not to mention their overall fitness. As you can imagine, again, what impact chemotherapy and other treatments would have on muscle volume, let alone strength, is also really pronounced. So what we see in our data when we're looking at randomized control trials of cancer patients is not that exercise just improves their fitness and strength, is that we can deliver exercise as a dosage that patients can tolerate and continue to do, such that it can overcome those detrimental effects of their treatment, or that they can regain from a very low starting point from where their treatment has really affected them functionally, and they can build that back up. So that we know that if this is beyond just exercise is going to improve your fitness and strength, it can overcome the impact that cancer and its treatment has on people's physiology, and we can deliver it in a way that actually allows us to counteract that, the negative effects of those treatments. And again, huge impact when you look at the qualitative data in terms of what this means for patients, their ability to care for their children or grandchildren, get out on the golf course, get back to playing tennis, whatever that means for somebody in their life is massive. And again, really not well represented in the research literature. As you can imagine, if we pull these kind of three big side effects that are very common across all cancers and that are typically not well managed across all cancers, people who are exercising and realizing those benefits are reporting improvements in quality of life. And again, the improvements are significant enough that they're overcoming the detrimental declines that we're seeing in quality of life that occur after somebody has a diagnosis of cancer. And the data's been able to, because of the wealth of data in the randomized control trials, now we've been able to unpack that a little bit more and put some statistics around what kind of that quality of exercise looks like. So it's usually the greatest benefits to health-related quality of life come out of combined aerobic and resistance exercise that involves supervision, or at least a higher level of supervision rather than home-based exercise. Not to say that it's not beneficial, but that's where we're seeing the most significant effects. Alongside this, there's a whole range of other side effects from cancer and its treatment that is really growing in evidence, and there's a lot of emerging evidence across these elements in particular in terms of the impact that very specific and targeted exercise prescriptions can have in terms of tailoring and making that prescription as safe as possible and also effective in counteracting a range of different side effects. So you can imagine something like this, the prescription that you would give for someone whose main side effect is cardiotoxicity, and they're looking at long-term health and benefit, is going to be very different than someone who's suffering from debilitating peripheral neuropathy such that they can't even get up and walk to the fridge. So there's a lot of kind of nuance around what that prescription needs to be. And again, the literature's got a lot to do in terms of catching up to what we can see with our patients and what benefits we can generate with our patients clinically. Really exciting areas here. These are all systematic reviews of randomized control trials that I've presented here. So a lot of data coming out in these areas as well. I think the next obvious question is, all right, we can generate these benefits, but what about the adverse effects of exercise? Is it safe for these patients? Especially when you think about cancer patients, there can be really complex system clusters. There can be a lot of high-risk patients where you can do something relatively simple that ends up putting them in hospital, whether it's just someone who's going to a gym when they have febrile neutropenia, or whether you're working with someone who's got highly fragile bones because of bone metastatic disease, and you could have a spinal cord compression, put them in hospital and never come out again. So there's a lot of safety considerations to think about when you're working with this patient population. What we see from the research literature is that exercise is safe for people with cancer, but there's a massive caveat here, right? There's no difference between adverse events between exercise and usual care, but this is all in highly supervised, clinical environments where if it is a home-based program, it's still having some level of interaction with some clinicians to make sure that prescription is safe. So the caveat is it's very safe when it's appropriately prescribed and monitored. The adverse effects that we see would be the same as what you would see in any kind of mental health or any other kind of physical activity intervention, and it's usually mild to moderate musculoskeletal symptoms. So very caveated discussion around the safety of exercise for people with cancer. But I think when we put all this together, we know that exercise is really something that is going to be a very potent medicine for people with cancer. And the question then becomes, how do we really implement this? I think, as you can see from the quality and the level of data that we have, it really mandates that exercise be considered as a standard component of cancer care. And alongside patients being prescribed their standard cancer therapies, we should absolutely be prescribing exercise, if only to counteract the side effects of those treatments, let alone for any potential survival benefits patients could get. But the data is enough to really mandate this. We know that if you withheld exercise from cancer patients, it would be harmful. They would have more fatigue, more psychological distress, they'd have higher functional impairments and poorer quality of life. So that alone is enough to say, hey, we need to be prescribing this. Aside from the survival benefits that we're seeing through the epidemiological data and now in randomized controlled trial data. And this has really kind of been now brought to the forefront through a number of different organisations. Here in Australia, we put together a big group of multidisciplinary experts to really have this call to action to say that exercise should be a standard component of cancer care, that every patient should hear about exercise from their cancer care team, that they should be recommended to be doing exercise, and in best practice situations, they should refer patients onto an exercise specialist who has experience in cancer care. Now, this position, if you like, has really been endorsed and supported through a number of different organisations internationally. We're really at the stage now that everybody's saying, hey, there's enough evidence, we need to put this into practice. So the question then becomes, are the guidelines actually being put into practice? And I'm sure, like many things, the answer to this is absolutely not, no. There's heaps more work we have to do in this space. So when you objectively measure how much exercise people are doing, only 1 in 10 are doing enough exercise to generate significant health benefits. And this is usually only looking at aerobic exercise as well. If you self-report this, it's around 2 to 3 people out of 10 who would self-report meeting kind of the guidelines, the minimum level of, well, not necessarily the guidelines, but the level of exercise that we're stipulating will produce significant health benefits. In terms of the data around how many health professionals are actually recommending exercise, this is a bit sketchy at best. It's all about self-report data. It's really hard to kind of gauge. People that are responding to these surveys are the ones who are proactive about responding to surveys in the first place. And even in those situations, it really suggests that only a very, a minority are actually recommending exercise. And I would definitely say that a lot of those people would self-report and self-acknowledge that they could do a lot better in terms of how effective that recommendation would be. And as you can see here, even in 50% of the people who regularly recommend exercise, they report that they have poor knowledge around how exercise can help their patients. So a lot to do there. In terms of what patients and clinicians actually want to be able to put these evidence-based guidelines into practice and be able to recommend exercise, it's actually pretty simple. And I think a lot of this is missed in what we focus on in terms of implementation efforts. But when we ask patients, and this is a sample of 450 cancer patients across all sorts of different types of cancer and within 3 years of diagnosis, patients very clearly said that they want their clinician to talk to them about exercise, have an actual conversation, for that conversation to be early in the care continuum, for it to be specific to them and specific to their situation in terms of their cancer and its treatment. And the most important thing that they wanted in terms of a resource to support that conversation was referral to a cancer-specific exercise specialist or program to help them actually act on that advice. When we ask clinicians, and this is 300 multidisciplinary clinicians, primarily nurses and specialists who work in cancer care, the key thing that they wanted was low burden referral options. They wanted to know how to tailor their recommendation based on what evidence is available, and kind of a lot of it was around functional status of their patients and kind of symptoms and side effects of their patients. They also wanted to have a really nice, tight summary of what the evidence is so they can quickly refer to that. And a lot of clinicians really talk about cost as being a big barrier. So, there's a lot of barriers in terms of having these conversations. I think I really want to focus on what the solutions are and making sure those solutions are informed and designed by the stakeholders who will actually be using them. So what I think the next question really comes is, if we can get that recommendation right, will people actually do their exercise? Will they take that exercise medicine? And this is data from, again, it's collated across a number of different studies, and I would say I can talk more clinically around this as well to give you a bit more insight if you're interested in this. But what we see from the research evidence is that cancer patients, both during and after treatment, can attend exercise programs. They can turn up to clinic-based programs. They can adhere to the exercise prescription given to them. And you can see here over 85% for both of those levels. Their discontinuation rate over a 3 to 6 month is only 12%. I would say that's, obviously that's in a highly controlled research environment. That would probably bump up to about 30% when we're looking at a bit more about, process evaluations and kind of service utilization. I think the key thing here is that that people are not only attending and adhering and not dropping out, but people beyond those that are actually engaging these programs are talking about their interest in exercise. The key question then becomes, all right, how do we pull all this together and actually engage people, especially the ones who have the highest needs? And we see that a lot of the time the clinicians will usually only talk about exercise as part of a person's cancer plan when they're younger, they're fitter, and they're already doing exercise. And what we see from the data is that these people don't really need that advice. The people that need the advice are the ones that are least likely to hear it from their clinicians. So poor functional status, older patients with complex symptoms are the ones would benefit the most from a recommendation and a prescription, and they're usually the ones missing out on that. I think another key question, this certainly comes in a lot as a barrier as a clinician, a cancer specialist, is this concern around whether or not patients are actually willing to pay for exercise services. And we see this a lot. Cancer, one of the side effects of cancer is financial toxicity. There's a lot of extra expenses that come on top of what kind of patients can get through the Medicare system. And on top of that, there's usually a significant period of time where people can't work, or they may not be able to get back to work at all. So this becomes a really important consideration. When we ask people, when we provide people with a very short synopsis of what exercise can do for them and what role it can play in terms of their cancer care, 94% of patients would pay for a Medicare subsidised consultation with an exercise physiologist, and 83% of people would say that they would actually pay for regular cancer-specific group-based sessions. And that's in line with kind of industry standard costs at the time of doing this research. And again, the things that kind of influenced whether or not people were paid, would be more likely to pay, it was people who were inactive, who had lower self-reported health, worse kind of functioning, were more likely to pay for those exercise services. So again, kind of opposite to what we would expect for what the clinicians are, how the clinicians are talking to their patients. So a really important component. I'll briefly say as well, we compared this to the clinicians, and the clinicians, even though they're seeing a much wider cohort of patients than that would kind of respond to this survey, they drastically underestimated how many patients would be willing to pay for exercise services. So again, I think the next question is, can we actually do this? Can we put an optimal service delivery mode together that's accessible for patients, that delivers exercise effectively in a way that minimises injury and maximises kind of adaptation for patients? And this is what we've tried to do, and what we've done through XMed Cancer, which is a not-for-profit organisation. And the whole idea of it is to deliver best practice at exercise medicine through community-based exercise facilities and gyms. So the data you can see here was off the first cohort of just over 200 patients. We've had over 2,500 patients go through it. The whole idea is really to make sure that we can deliver those outcomes in a scalable model of care that is utilising existing infrastructure and workforce, so we don't have this kind of big bottleneck that's associated with the tertiary centres and the hospitals where there's huge wait lists. And I think we can do this because of a deep understanding of what components need to be pulled in what direction to make it a very simple, easy process for clinicians, for patients, and allowing this kind of whole process to flow really quickly. So I can talk in much more detail around that if anybody's interested as well. But I think, altogether, when we pull this all together, we can really say that, if the effects of exercise were encapsulated in a pill, every single patient who has cancer would be prescribed it. It would be on the PBS, that there would be no reason that this wouldn't be fully funded through Medicare and so on. So, the benefits that we see dramatically outweigh the challenges that we have in terms of implementing this. And I think it's really on us as people in the exercise oncology field to do a much better job of helping kind of get this implementation into practice. Now, there's still heaps more questions we have to ask and answer. There's a lot more research that we have to do. Really simple questions like, what's the least amount of exercise someone can do to get a benefit? When's the most effective time for them to start doing exercise? All these kind of things that, how can exercise counteract, how does it interact with treatment, or what kind of mechanisms are underpinning all this stuff? We have a lot more we need to know, but we absolutely know enough to say that every patient should have access to this medicine and that it is an effective adjunct therapy in cancer care. So really happy to discuss kind of any element of the presentation that you guys are interested in and go in much more detail. I really tried to make kind of a bit of a summary of everything we know. So hopefully you guys can have some questions and we can continue discussing this in much more detail.
Thank you so much, Prue. I was trying to write furiously as you were speaking. It was really, really interesting, and you've covered so much. So if you have questions, you can unmute or put up your hand, and then I can see who's got questions, and I'll try to navigate the mouse on the different. Just while everyone else is thinking, one of the things, okay, I'll give Tani a chance because I know she's doing research in this area. Go for it, Tani.
Thanks, Tracy. Thanks so much, Prue. It's definitely right down my alley, this sort of stuff. So we're currently doing a lot of this in breast cancer patients. You say, I guess I'm just curious, predominantly what sort of region is your data coming from? Is it primarily metropolitan? Because there's lots of good numbers there. I'm just wondering if that's sort of translatable into regional and rural contexts. I, like you, think that exercise therapy or any sort of exercise specialty should be part of Medicare. But sort of what challenges do you think that you haven't really identified if it's more metropolitan, and how we can potentially take it further out, sort of regional, rural?
Yeah, it's a huge challenge, right? So, I mean, most of the data is going to be from metropolitan participants. I mean, our survey data is really only about 20 to 30% regional, you know, and how many of that's rural, especially in Victoria. Like, there's not that much rural in Victoria. It's pretty big when you compare it to regional, you know, rural WA or outback Queensland, Northern Territory. So look, the vast majority of this data comes from metropolitan data sets, and most of it in terms of the randomized controlled trial data is in clinic-based settings. So there's heaps more work we have to do in terms of looking at various modes of delivery. A lot of the work that I'm doing, I mean, digital solutions is obviously an important component of that. Telehealth is helping, you know, bridge that gap. But with something like this, and especially when you're working with complex patients and high-risk patients, you absolutely need to have someone on the ground helping with that. So I think, you know, in terms of workforce development, there's ways that we can really enhance regional capacity, and it's certainly in Victoria something that I'm working on. We do upskilling through all the regional integrated cancer centres here, and the Cancer Council helps in terms of some of that kind of program implementation as well. So look, there's a good focus down here in terms of putting this into practice. It's nowhere near where we need to be.
Yeah, it's a bummer.
I mean, I think that, you know, workforce capacity is going to be the challenge when you talk about implement this. Obviously, as things progress, you know, there's a lot of really cool innovations that we can do with technology now that's going to help that. I think a lot of people are still going to want the touch and feel of a real person.
Thanks. I have a follow-up question, but I'm going to wait and give Karina an opportunity to ask her question first.
Thanks, Tracy, and thank you, Prue. That was great. I'm an AEP, and your 2016 TED Talk definitely sparked my interest in the space, and I'm so passionate about integrating exercise into cancer care. So yeah, it was amazing. Thank you. I guess off the back of Tani's question, are there any initiatives or programs that have successfully integrated AEPs into rural and regional cancer care that you know of?
Oh, I mean, I think there's plenty of examples here in Victoria. So, I mean, you know, we have centres at, like, I mean, Albury-Wodonga Regional Cancer Centre I did some work with. There's, you know, throughout Shepparton, there's a whole bunch of exercise physio. I mean, there's pockets all over the place. I was just, you know, I just enrolled someone in one of the professional development courses from the Gippsland area now. So I think there's, you know, there's definitely ways that we can, again, build this kind of community. There's still going to be, you know, like, I think the ability, well, I shouldn't rat on ESSA, but I think ESSA's, you know, like we had some really cool networking opportunities and and this kind of ability to help each other as a field. And I think that, you know, like we can get more network kind of work like that to kind of, you know, just have those more, you know, conversations, like let's scenario out this complex case, you know, like you don't want to have all these EPs and physios being really isolated in those centres, and having the ability to then talk to other, you know, colleagues or more experienced people in exercise oncology is going to be really valuable in terms of that workforce capacity development. But, you know, like I think there's a lot, like we need to do a lot more of that. So I think it's possible. I don't think the solutions are hard. It's just going to take time and effort and money to do it.
Sorry, if I can ask a follow-up question. From what you see, is it mostly private practices working in that space in rural and regional areas, or are there more of these like AEPs coming into these cancer centres?
No, there's more. I mean, yes, but there's private practice is always going to be a huge component of the workforce for this, and I think rightfully so, because, you know, you don't want patients continually coming back into the hospital and staying in the hospital that whole time. Like, you want to transition them out.
Yeah.
So I think that's happening more and more now, but there's more and more appointments within regional cancer centres. There's certainly I think, you know, there's a desire, I could say, from the clinicians. So the cancer clinicians, the specialists and the nurses are very keen for this to happen. They want, you know, the most important thing to them is having, you know, referral options and low burden referral options. So it's something that you tackle all the time. It's like, I'd love to talk to my patients about exercise. I don't know where to send them, so I'm not going to talk to them about exercise. So having that kind of referral network and those options and making sure that that's easy for them to do is such low-hanging fruit.
Thank you.
Thanks. Tani, do you have another question, or is that a legacy hand?
I just haven't put it down, sorry.
Prue, you touched on one of the questions I had, and you've mentioned it now as well when you say low burden referral options. What can you explain to me what that means for a clinician? Is it that we need, because I'm an AEP as well, but I'm in danger, I think, clinically at the moment. But is it, I remember when I had my practice, I used to take referral notepads to the doctors in the area and so on. Is it something like that? Yeah, like I think I just like a sense of what it is that.
I think, you know, it's easier regionally because you're not having to have, you know, one specialist who's treating people, you know, all over a metropolitan area. So if it's a small regional area, it's a lot easier. Then it can just be that kind of awareness. And I think if I'm talking from what we know from the data from clinicians, so when I talk about clinicians, I'm talking about cancer specialists, so all across the specialities, and nurses, and then radiation therapists and anesthetists and so on. I mean, the biggest burden they have and the biggest thing they say is, I don't know who to refer to, and I don't know, you know, how do I deal with my patients who live in, you know, Bendigo or something. Although Bendigo has really great exercise physiology services, you know, they're the key things. So I think, you know, it's really easy to say, like, you know, just go to the ESSA website and search for your postcode. I think the changes that they made were terrible, and it makes it a lot harder to find an exercise physiologist. The doctors aren't going to do that, you know, like and that means that, you know, that you've got to remember that they've got like these really complicated series of treatments and side effects and questions that people have that they have to get it through in a very short period of time. So that step of having to go somewhere to search someone is too much. You know, it's got to, when I say low burden, it's got to be exactly that. They've got to know who you are. They've got to trust who you are. They've got to see the results that you can deliver. And that's got to kind of be evidenced as well for them, whether it's seeing the patients talk to them about you and your services, or, you know, actually seeing hard data that you're producing from the benefits.
So would that then put the onus on us as AEPs and as the physical activity community then to get the word out? Because, like you say, it's a crowded appointment and a crowded space for those clinicians.
Yeah, I mean, I'll tell you what I didn't present and what the focus of my work has been is just to do exactly that, is to basically make it easy for cancer clinicians to discuss exercise, and one element of that is making sure that there's a low burden referral option for them, you know, so it's quick, it's easy, they don't have to think about it. The other element is making sure it's aligned with patient preferences, right? So that clinicians know what they need to do to be able to get patients to the door of the exercise specialist. And I think, for us as a field of researchers or, practitioners in the field, we need to do that work. It's not going to happen in the cancer space. So if we don't do it, nobody does it. And you know what, look, and that's not an ideal situation, right? Like, I mean, if I'm a cancer patient, I'm turning up, my doctor doesn't tell me something that has this much evidence that's going to benefit my treatment and my experience of cancer, like, I would feel very dirty about that. But that's just the reality of where we're at. So it's absolutely, the onus is absolutely on us in the exercise space to make it as easy as possible for clinicians to have those conversations.
Yeah, I agree. And I think a lot of us on the call today, and even in the physical health stream, we come from a physical activity background. So it would be interesting to hear perspectives of people that are sort of the non-physical activity background. So feel free to jump in and add questions.
And I will say that as well. I think there's, there are heaps of clinicians out there who are 100% on board with this without any kind of influence from an exercise person, right? So, like, there's a lot of clinicians who will be definitely proactive about it. But I think if we're talking about trying to get, this, equitable access to at least information, it's not going to happen without a lot of work and a lot of advocacy.
And I think that when you get a cancer diagnosis and you're going to the doctor, there's this bombardment of information and it's overwhelming. So I think even just having some written material, sometimes the doctor gives you an example of exactly where they're going to operate and what they're going to do, and sort of a picture tells 1,000 words. So I'm sure you've covered that already, but it might be that we can give the patient something to take home, because it is overwhelming to digest all this information each time we go in for treatment.
Totally. So that's a big component of what we're doing at the moment. So we're co-designing those kinds of resources. So what people want from their cancer care clinicians and what they would actually use to then do exercise, right? So that's from a patient's perspective. From a clinician's perspective, we're co-designing the things that they want and they would routinely use to be able to have conversations that are effective when efficacy is defined as uptake of, patient uptake of that advice, so actual exercise, right? So, I mean, I think there's a lot of assumptions around this, and this is why we've got some data to back it up now. There's this view that too early people won't listen versus too late, I wish somebody told me about this earlier. There's there's schools of thoughts around that, in terms of, some people say, I couldn't have handled any information then. Other people said, I only got information here, I wish I would have got it then. So, there's a lot of kind of difference in personal opinion, but what we know overwhelmingly from if you look at the quantitative data across patients, is the earlier the better.
I love the idea of the co-design, and I think that's going to be, I can't wait. You're going to have to come back and tell us all about it.
Yeah, no, well, yeah, it's not too far away. I think a lot of the time, and this happens, everywhere as researchers, we think we have really good ideas in terms of what's needed to put this into practice, but then the clinicians just won't use it. And, unless I think this is the advantage of me working so closely with clinicians for a long period of time. And then also as exercise people, you spend heaps of time talking to people who you're exercising with, right? So you've got a pretty strong kind of sense of what those stakeholder needs are and what real world implementation looks like. So, we've got to be far more pragmatic around what we're doing in terms of putting this into practice. A theoretical best case situation is never going to fly.
Absolutely. Rebecca, I see you have your hand up, so go for it.
I was just going to say I'm one of those ring-ins today. I don't come from an exercise or physical health background at all. My background's psychology. But I was wondering, in terms of from a support group perspective, because I am involved in multiple parent and also personal support groups for various different things, particularly for congenital physical disability issues that I have. And I thought, how well does this sort of, information get disseminated in support groups? Because if it's not getting through from your medical team, then maybe that would be another angle. just a thought that, you know, does it get disseminated in these kind of support groups, and how could it be done better, I guess?
Yeah, I think it's hit and miss with in terms of the support groups. You know, it really comes, I mean, I've done heaps of talks at support groups, so some are very proactive about it. It comes down to kind of who's running it and what they're interested in. I think, you know, we do a lot of work with the cancer organizations, and the cancer organizations are very on board in terms of, you know, helping at least have information about exercise available. What we know from patients is that if it comes from their doctor, especially their specialist, they're much more likely to act on it than if it comes from somewhere else, right? So having that kind of level of authority, and if they say it in a way that is, you know, I don't know anything about exercise, but I know about the research, and this is something you have to do. You know, it's one of the best things that you can do alongside your, you know, do your treatments. So that level of kind of endorsement, I think, becomes really important, especially when you think about it from a behavioral point of view of how much that you know, shifts that person's attitude towards deciding that exercise is part of their care. Yeah. So I think, you know, like there's a whole different way, you know, range of avenues in terms of disseminating this information. The most effective is going to be through the clinicians. The other thing I will say as well, you know, kind of just talking about support groups, I mean, you know, there's a lot of discussion around social prescription as well, and, you know, isolation and all that kind of stuff. And I think, you know, what we see from delivering exercise in a way that is group-based but person-centered, you get so much more bang for your buck in terms of what this means for patients. So, you know, like if you really want to talk about like what the kind of overall benefits are and how to deliver it in a way that's going to help people kind of continue to engage in exercise and get the most benefits from it, like doing it in this kind of, even a support group kind of meeting is a great way to do that.
Yeah, and that sort of social peer pressure to keep doing it.
Oh yeah,
can be really helpful. Yeah.
Yeah, I mean, and that's absolutely right. I mean, we have people turn up, you know, just because someone, you know, like their group is going to be there. So in the same way that, you know, people will turn up just because you're paying for someone to be there to supervise, right? So that the social component of it becomes really important.
Yeah.
It's not essential, so, you know, it doesn't mean that you have to have it, but it is a really useful tool and tool belt.
Yeah, fantastic. It's really interesting. Thank you, Prue.
And I think that social part would also help to sort of amplify the mental health and well-being benefits as well, you know.
Yeah, and I think, sorry to jump in there, you know, there's a lot of different lenses you can look that through from a men's health perspective, you know, getting a bunch of blokes together to talk about their feelings is probably going to be a lot more challenging than getting a bunch of blokes together to do some exercise. And while I'm riding on the bike next to you, I might, you know, accidentally fall into a conversation after we have a bit of banter and we joke about something that's really quite serious, right? So it can open up conversations, and there can be stage of life issues that are similar. You know, there's a whole raft of things that allow that exercise can kind of wedge you into a whole bunch of different kind of support structures and benefits that you can get there.
I actually have so many other questions, but I don't want. One of the things, just because I'm keeping my eye on time, and I put up the web address for your XMed Cancer link, and then you had a slide before that on the call for action, and I think I was just wondering, for others that are interested in this area, how can they get involved in that call for action? Is it over? Is it done? And then also, how do we as Manna help you advocate and spread this mission, if you like?
Well, the call to action is really through the Clinical Oncology Society of Australia is a position statement. So it's really there to give some clout to, you know, any individual exercise practitioner who walks up to a cancer specialist and says exercise is good for your patients, and you can say, no, it's not me saying it. This is all these experts saying it. You know, it's coming from the peak professional body in clinical oncology in Australia, and it's endorsed by, you know, 30 plus other influential organizations. So I think, you know, in terms of, you know, getting on board that, it's basically just using the statement in your everyday practice and leveraging off that kind of clout that comes with that call to action to try and, you know, make local changes in the accessibility patients have to exercise services.
Thanks. It's navigating my mouse proving to be challenging today. Are there any other questions from anyone else? Just looking at my screen. Prue, I think that was really, really awesome and a host of information to get through. And from my perspective, I really enjoyed the way you walked us through the journey and showed us all the evidence. It's really helpful, and seeing the results of the meta-analyses and so on to support the argument. I would encourage you that if there's anything that you'd like us to disseminate via Manna or via the website, please feel free to reach out. And even if it's thinking about broadening out into regional communities, and there could be some people here that might be able to work with you. And if you are comfortable, let us know if we can send your information to the people that attended today, your email address, in case, and you don't need to answer now, but in case they want to reach out to you. And let me just go through my notes here. Yeah, I think that's about. Oh, and then I also put the links up in the chat for those of you that are not part of Manna that would like to join as an affiliate researcher or HDR student. If you go to that website, you'll see you can also join as a community member, because one of the, I think the strengths of the Manna Institute is that we have people with lived and living experience as part of the group as well. And it's I found it quite valuable in gaining insights into thinking about what research is worth doing, what questions should be asked, and also advice on planning. So if there's no other comments or feedback, I'll give you 5 minutes of your day back. And again, Prue, thank you. It was truly amazing. And I try to keep track of the comments, but I can see from what people have said, they've absolutely loved it. And just even your timeline graph at the start, I was just going wowzers. And thank you, Chris, for introducing us to Prue. So with that,
opportunity. All the best.
Thank you. Bye-bye.
Thank you, everyone.
Thanks, everyone.
Thanks, Tracy.
Bye-bye.